colleague Dr. Rana Tarek, discussing emergency embolization in massive hemoptysis.
Good afternoon, dear professors and colleagues. Thank you for your attendance. Okay, this is Rana Khafagy, lecturer of Interventional Radiology at Ain Shams University Hospitals, and my talk today will be about emergency embolization in massive hemoptysis, specifically the bronchial artery embolization. So the outlines of my talk will include a brief introduction. Quickly, I'll be talking about the causes of hemoptysis, the pathophysiology, and we will talk about the embolics briefly. Then I will show you some cases, and finally we will conclude. So to introduce the efficacy, safety, and utility of the bronchial artery embolization in controlling hemoptysis within an acute or elective settings have been well documented in many reports, with clinical success reaching up to 90 to 100% in massive cases. And the source of bleeding in 90% of the cases is the bronchial arteries, and that's why we are targeting, usually in the cases of hemoptysis, the bronchial arteries. 10% will be from the pulmonary circulations or the aorta. So the causes of hemoptysis, it can result from various lung pathologies. Most commonly are the pulmonary tuberculosis and the bronchiectasis, and in the developing countries like Egypt, pulmonary tuberculosis is very high. Also other causes would be bronchogenic carcinoma and fungal infections. Others are random, maybe vasculitis, lung abscess, aneurysm, congenital cases, etc. So the pathophysiology for the enlargement and the bleeding of the bronchial arteries, in many acute and chronic cases, the pulmonary circulation is usually reduced or occluded at the level of the pulmonary arterioles, and that's why, due to the hypoxia, vasoconstriction occurs and intravascular thrombosis occurs, along with some vasculitis if it is present, and that's why we usually find the bronchial arteries proliferating and hypertrophied to replace the pulmonary circulation. Also, vessel erosions and neovascularizations in cases of chronic infections or tumors can also contribute to the pathophysiology of the hemoptysis. Regarding the embolics, and according to the literature, in earlier years, maybe before 2008, gel foam-based embolic materials were the predominantly used ones, and then till 2012, the PVA-based embolic materials were preferred, and recently, after 2013, they started using the glue or the n-butyl cyanoacrylate, and the literature showed significantly a lower rate of recurrent bleeding, and there were more reports on the use of the liquid embolizing agents for bronchial artery. However, there is still no consensus on the best embolic material for bronchial artery embolization, and in my institute, of course, at the IR unit at Ain Shams University Hospitals, we still prefer using the PVA particles of size 300 to 500 micro. So I will start with the cases. Our first case, he was a 55-year-old patient with history of TB, presented to the ER with attacks of massive hemoptysis, and this is the chest X-ray. We can see features of interstitial lung disease and fibrosis complicated with bronchiectatic changes, and CT confirmed the findings. And this is digital subtraction angiography. We can see severe parenchymal neovascularization with bronchial artery hypertrophy and tortuosity affecting the right middle lung zone, matching with the findings we found in the CT and the X-ray. And this is post-embolization using 300 to 500 PVA particles. We can see that the disappearance of the blush with successful embolization. So another case is a 37 years old patient with bilateral bronchiectatic changes. He presented to the ER with hemoptysis and hemoglobin drop, and this is CT here revealing mainly left upper lung lobe bronchiectatic changes. I'm just showing the key images. In this case, as we can see marked bronchiectasis, and here the bleeding around the bronchiectatic cavity, and this is an X-ray of the dilated bronchus with fusion of the angiography images. You can see this is the cavity and the hypertrophied bronchial artery with bleeding inside, and this was post-embolization. We still have some residual, and so we injected more. And this is the final control angiogram. We can see disappearance of the abnormal blush and the contrast extravasation. So this is before and this is after. Okay, this is another case of bronchiectasis with multiple bleeders. We can see here this the CT angiography was done. This is the lung window. We can see bronchiectatic changes here on the right side, upper lobe, upper and middle zone. Also on the left side, especially on the basal lower lobes. Also we've got, and this is the mediastinal window. If we can check around the aorta, we can see the hypertrophied bronchial arteries. Okay, so selective catheterization here, we can see the right-sided pathological hypertrophied bronchial artery. We can see a fistula with early filling of the pulmonary vein. So we upsized the particles. First we entered using microcatheter, and we upsized the particles. We used 500 to 700 PVA particles, and then we finalized with 300 and 500 particles, and this is the final control angiogram with successful embolization. The same case, it had also another bleeder, hypertrophied tissue, and this is post-embolization, and this is another bleeder. This case took about 3 hours. We have embolized several hypertrophied bronchial arteries. This is another one also. This is all hypertrophied. We usually don't find these findings on normal catheterization. And this was the last bleeder that was also embolized successfully. This is a case of pulmonary mucormycosis. We can see here this is post-TB, and he had upper right lung cavity with on top fungal infection mycetoma. This is pre-embolization, and we can see the abnormal blush and the hypertrophied bronchial artery, and this is post-embolization with disappearance of the abnormal blush. This is a case of bronchogenic carcinoma. He is a 45 years old patient with known upper lung lobe, presented to the ER with repeated attacks of massive hemoptysis, and the CT images reveal right upper lung lobe mass. And we can see here selective catheterization, the massive blush corresponding to the mass we have seen in the CT. We advanced a microcatheter for more selective catheterization, and then post-embolization using 300 and 500 microparticles. This is successful embolization with disappearance of the abnormal blush. So this is before, this is after advancement of the microcatheter, and this is after embolization. Our sixth case is about bronchial artery pseudoaneurysm. We can see here and a pseudoaneurysm with there was a fistula with the pulmonary vein, and this is also post-embolization. This is a case of vasculitis, and he was known to be positive for anchogranulomatosis vasculitis. He was presented with hemoptysis, and this is the axial CT images. We can see bilateral areas of interstitial thickening, nodules, and some faint ground glassing patches. And here on catheterization, هنا لما قسطرنا البرونكيال artery قادرين نشوف الابنورمال بلاش very severe. هو ده اللي كان عامل نزيف للبيشنت، وده بعد ما قفلنا ب 300-500 particles البلاش اختفى والبليدنج stopped. طيب بس يعني حاجة أخيرة لازم نبقى متأكدين لو إحنا عندنا bleeding ما ننساش الاكتوبيك برونكيال ارتريز، يعني مش شرط كله يبقى طالع من الاورطه، ممكن يبقى عندي اكتوبيك برونكيال ارتريز طالعه من اوريجينز مختلفه. ده ليفت سبكليفيان، ولما قسطرناه سوري اهو قسطرنا البرانش منه، لقينا ان هو برضو مدي الليفت ابر تو ميدل لونج زون بابنورمال بلاش، وده برضو محتاج يتقفل. يعني احنا بس ما بيبقاش التارجت بتاعنا البرونكيال ارتريز، لو انا اقدر اتاكد ان انا ما عنديش اكتوبيك برونكيال ارتريز كمان بقفلها. برضو لازم ابقى مايندد بالسباينال ارتري انستوموزس، زي هنا مثلا في الحاله دي بعد ما عملنا كاسترايزيشن للابنورمال برونكيال ارتري قادر اشوف سباينال برانشز رايحه تو ذا ميدل. انا ما اقدرش اعمل امبولايزيشن من هنا، انا لازم اباي باس البرانش ده، وبالتالي انا استخدمت مايكرو كاثيتر ودخلت فور مور سوبر سيلكتيف كاثيترايزيشن للارتري البليدر، وباي باست خالص السباينال ارتري وعملت كومبليت امبولايزيشن. Follow up: no other hemoptysis attacks were encountered throughout the follow up period of all the previously demonstrated cases. كل الكيس الحمد لله البليدنج stopped وما كانش عندنا أي major complications. So to conclude my lecture, hemoptysis causes are numerous, with bronchial arteries being the most common source of bleeding. زي ما أنا قلت 90% من الحالات من الهيموبتسيس هتبقى السورس بتاعنا هي الابنورمال bronchial arteries. Hemoptysis can be a life-threatening condition if massive, which will need urgent interference. وبالتالي البرونكيال artery embolization ده واحد من ال safest وال effective procedures in the management of hemoptysis, especially on emergency cases. Thank you very much.